Okay, everyone. So we're starting with the depression or first topic of psychiatry. Depression is a common term that most people know. In medicine, we use a more specific term, which is major depressive disorder. It's very serious mood disorder. Patients with depression, they feel low moods, low energy. They have no motivation to do anything. They feel anhedonia, which is loss of interest or in activities, or the loss of pleasure from activities that they used to enjoy. Uh, if it is mild, uh, it may not manifest as functional impairment, but if it gets severe enough, it can cause significant decline in their functioning or daily activities, even leading to psychosis in some cases. Um, by definition, depression is a common and serious mood disorder characterized by persistent feelings of sadness, emptiness, and or loss of interest or pleasure that we also call anhedonia that significantly impairs daily functioning. For diagnosis of depression, we have DSM-5, Diagnostic and Statistical Manual of Psychiatry's fifth generation, their diagnostic criteria. For a major depressive episode, 5 symptoms must be present. Out of the 5, one symptom has to be either low mood or anhedonia. If low mood or anhedonia is not present and other symptoms are present, we cannot call it depression. It is another cause that is, it is something else that's causing the patient's symptoms. Remember, the criteria is, you can remember it as a mnemonic: my pass, MI pass ECG. MI or me or my or however you want to pronounce it. M stands for mood, I is for interest. Out of these two, one has to be present. If it is not present, it's not depression. P stands for psychomotor, agitation or retardation. A is for appetite. S stands for sleep or sexual dysfunction. And the second S is for suicidality or feelings of killing themselves. E is for energy, C for concentration, G for guilt. We will go over all the symptoms in a few minutes. For diagnosis of depression, at least one of MI should be present, either mood or interest. Depressed mood, which should be most of the day, almost every day, or loss of interest or pleasure from activities that they enjoyed, and it should be in most of their daily activities, not just one thing. Secondary symptoms or symptoms that we need along with the mood or loss of interest: psychomotor agitation or retardation. Sometimes patients with depression experience agitation of psychomotor activities. For example, talking, they talk too fast or they talk too slow. Sometimes they experience retardation. Agitation is talking too fast or walking too fast. Retardation would be walking too slow or talking too slow. Appetite changes. Some patients experience hyperphagia or eating more than they should be. Some patients experience loss of appetite and they can lose weight. S stands for sleep and sexual issues. They can either have insomnia or hypersomnia or low libido. Second S stands for suicidality. Patients with depression can feel hopeless and eventually feel like life is not worth living and sometimes act on that impulse and unfortunately kill themselves. E is for energy. Most patients with depression, they do not come to the clinic saying that I'm depressed. They come to the clinic saying, I feel tired or low energy, or I'm very low on energy. I don't feel like doing anything. C stands for concentration. And in elderly, we would also consider cognition. Sometimes the elderly do not come to clinic saying that they have low mood. They say, I'm having trouble remembering things. And then when you question them, they agree or they endorse feeling low and lonely, etc. And then we can diagnose depression. G stands for guilt or worthlessness. Sometimes these patients may feel like they are guilty of something that they had no fault in, or they are worthless, or life is useless or worthless. In all cases, if there is low mood or loss of interest in activities or loss of pleasure, which is the anhedonia, we would need to have 4 more, and these symptoms should be present on most days for 2 weeks. That is called an episode of depressive symptoms. Once we have a single episode of single depressive episodes, we can consider that as major depressive disorder. Now, there are some types of depression. First one is obviously major depressive disorder. For this, we have to have at least 2 weeks of a single episode, or the episodes must be recurrent. If they're not, even if they're not lasting for 2 weeks, but they're recurrent, then we can call it major depressive disorder. 5 symptoms must be present or more, and one of them should be either low mood or loss of interest with functional impairment. It can be mild, moderate, severe, or marked functional impairment. Major depressive disorder, this is the most common type of depression that you would see in your clinical practice, and it's very likely to show up on your exam. We would diagnose patients based on a single episode if it has lasted for 2 weeks, or recurrent episodes based on their history. Remember one very subtle thing about it. If you have a patient who is depressed right now, you must always rule out bipolar disorder. How you rule it out? You ask about episodes of mania or hypomania, which is elated mood. If they have grandiose and risky behavior with it, then it's mania. If they don't have grandiose or risky behavior, then we can say it is elated mood. They slept less, they didn't need much sleep, they were full of energy in doing things and taking initiatives, feeling more confident. Those would be hypomania. If they have grandiose or a plus risky behavior, then it is mania. Now, the second type of depression is dysthymia. We don't use dysthymia term anymore, but remember it for exam. Sometimes they use obsolete terms too, which is persistent depressive disorder. For this, if it is an adult, they should have 2 years of mild depressive symptoms. And for children, it should be 1 year. Symptoms are 2 to 3 symptoms, but remember one symptom again has to be either low mood or loss of interest. And it is milder form of major depressive or disorder or depression. But the problem with this persistent depressive disorder is that it is very long lasting, and treatments usually need a longer duration. Sometimes people with dysthymia or persistent depressive disorder, they can get an acute episode of major depressive disorder. You can call it double depression, but it's not used in clinical practice. Now, patients with dysthymia, they are likely to experience a major depressive disorder episode within 10 years of developing this milder form of depression. Next form, we have seasonal affective disorder, or SAD, SAD or seasonal affective disorder. These patients experience symptoms when it is winter or autumn, starting from October to March or April in some places, sorry. And their symptoms get better after once spring starts and we have more sunlight. It is believed that it is caused by low exposure or less exposure to sunlight. For seasonal affective disorder, we have a specific form of treatment that we call light therapy. They're exposed to light that mimics the sunlight, and this helps very good. And they respond well to this light therapy. Next type of depression is depression or dysphoric disorder that occurs around the menses. Some women experience low moods and hopelessness, all several symptoms of depression around their menstrual cycle. It starts a few days before menses start, and then it resolves once their menses clear out. Remember, this is different from premenstrual syndrome, which focuses more on the severity of the pain symptoms, not on mood. Most severe form of depression is depression that presents with psychotic features like delusions or hallucinations. If someone has psychotic features with depression, their treatment is starting antipsychotic immediately and augmenting that with an antidepressant. For these patients, SSRI or antidepressant monotherapy is not recommended. It can cause more harm than benefit. Sometimes when they have delusions with depression, they may need to be involuntarily admitted to the hospital. We will discuss these when we are doing the MCQs cases. But remember, sometimes depression can present with psychotic features. We have something that we call postpartum psychosis. Some women experience psychotic features after giving birth. In these cases, treatment is starting with antipsychotic and then adding antidepressant. We don't start with antidepressant alone. Now, when it comes to pathophysiology or how depression happens, there are several theories about it. The main theory or the primary theory is that it's caused by the deficiency of monoamine neurotransmitters like serotonin, etc., which causes symptoms of depression. There are some additional mechanisms being proposed for depression. One is that the enzyme which breaks down monoamino oxidase, it is overactive, and that's why this overactivity of this enzyme causes these monoamines to break down quicker and have lower concentration in the synapse between nerves, and this causes symptoms of depression. Another theory is that there is inflammation around the cerebrum. That's why these people with depression are depressed. There is another theory which says that hippocampus, the part of brain which is responsible for memories, emotions, etc., it does not produce new cells, and that's why people get depressed. There is another theory which is hypothalamus pituitary axis dysfunction. Sometimes it's been observed in some cases that high levels of cortisol or abnormal response to stress can cause people to get depressed. One main theory is also genetic factors. Sometimes multiple of these different pathways, they are present in one person, and it's usually more of a genetic factor which causes them to get depressed. Now, neurotransmitters that we have in the brain, first one is 5-hydroxytryptamine or serotonin. Serotonin is responsible for regulating mood, appetite, sleep, and sexual function. If serotonin is deficient, depressed mood, loss of interest or pleasure, and insomnia or hypersomnia has been noticed in patient. Serotonin is targeted by medications such as SSRIs or SNRIs, which are selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors. The second important neurotransmitter when we are discussing the pathophysiology of depression is norepinephrine. Norepinephrine, it helps with attention, arousal, and overall energy levels. If it is low in concentration, we may feel issues with our concentration and we may feel tired, even though we are sleeping 10 hours a night. SNRIs and some other medications, they target norepinephrine levels. They work by raising the level of norepinephrine in the synapse between nerves of CNS. Dopamine, I think almost everyone knows dopamine. It's the neurotransmitter that is for pleasure or for movement. If it gets deficient, we get anhedonia, low motivation, and Parkinson-like symptoms. Bupropion and some other medications, they target dopamine reuptake, and they work by increasing the level of dopamine inside the brain. Now, antidepressants in general, they act by raising the level of neurotransmitters in the synapses. Once we have neurotransmitters deliver a message between nerve cells, their reabsorbed or reuptake happens by the neuron that has sent the impulse. What these medications do, they come and disable or inhibit the enzyme that's responsible for the reuptake. That's how the levels stay higher, or if they are low, they come back to normal once we start medications like SSRIs, SNRIs, etc. All right. Now, when we discuss etiology or causes of depression, in most cases, we do not find any cause for depression. We have some risk factors, most importantly, genetics. If someone has family history of depression, their risk is 2 to 3 times higher than people who don't have family history. Second biological factor would be imbalance between neurotransmitters, specifically serotonin, norepinephrine, dopamine. Third is dysfunction of hypothalamic pituitary axis, hypothalamic pituitary adrenal axis. Next, biological risk factor for developing depression is inflammation, specifically in the cerebrum of brain. It has been noted that some people with depression have elevated inflammatory markers. Some medical conditions, they can cause depression. For example, hypothyroidism is present in some patients of depression. When we are we're doing workup for depression for someone, TSH is one of the tests that we do to check if they are depressed because they have hypothyroidism. Parkinson's can cause depression, strokes, myocardial infarction, diabetes, cancers, etc. Almost all these conditions can cause depression. Some medications like beta blockers, interferons, antiretrovirals or anti-HIV medications, steroids, they can cause depression. Changes in hormone levels, for example, women are very likely to, not very likely, sorry, women may develop depression around peripartum time, around the menopause or perimenopause, and women who use oral contraceptives, they have slightly higher risk of getting depressed or getting depressed after stopping the oral contraceptives. Okay. The second type of factors that are implied in depression is psychosocial factors. Stress and trauma. Continuous stress can cause anxiety, depression, and other mental health illnesses. Children who experience abuse during their developmental years, they are more likely to get diagnosed with a mental health illness like depression, anxiety, ADHD, etc. Sometimes people who are in war or situations where their life is threatened, they may experience PTSD, and PTSD can then be comorbid with depression. Some personality types, specifically those that have negative thinking predominantly, they are more likely to get depressed. Sometimes people who are bullied or people who have low self-esteem, they can become depressed. At last, we have learned hopelessness. Some people, they, through their situations or through their life experiences, they learn hopelessness or they get adapted to hopelessness, and that's how they get depressed. Third types of factors that are involved in leading to depression are environmental and social factors. Social isolation, especially in the elderly, it's a very important thing to remember that elderly are very likely to get isolated socially because of their health conditions. They have issues with hearing, they cannot communicate properly with their friends. If they have comorbidities like Parkinson's, they have issues with walking, etc., and they're very likely to be isolated socially and get depressed. Sometimes loss or grief, death of someone loved, or a breakup, this can lead to an episode of major depressive disorder. Changes in life situations, especially in adolescent or in children, these can cause issues with adjusting to new environment or new situations. If it is not severe enough, we can refer to it as adjustment disorder, but sometimes it can be severe enough to either cause anxiety, generalized anxiety, or depressive disorder. Substance abuse, alcohol, and other drugs. Uh, for example, cocaine, if someone is withdrawing from cocaine, they can get severely depressed suddenly. It's kind of a symptom of withdrawal in those things. Um, Sometimes we don't really have any other risk factors. The only risk factor is that someone is a female or woman. Women are more likely to develop depression. Men are more likely to commit suicide, but women have higher incidence of depression. Age can be a risk factor, but it's not very specific. Depression can occur at any age. Usually people experience it in their adolescence, in their 20s, 30s, or even older age. Some races or ethnicities have higher rates in comparison to others, specifically if they are from a country which is at war or currently experiencing another natural disaster or another situation which is not favorable. Marital status, sometimes we see higher rates of depression in divorced or recently widowed or widowers. These are likely to have grief and bereavement and likely to develop depressive disorder. Finally, people who have medical conditions or mental health conditions like anxiety, substance use, or patients with chronic pain, they can develop depression or get depressed. Now, in clinical practice, most times patients with depression, they would not come saying, I think I'm depressed. Most of the time they will come and say, I feel very tired, or I don't really have any energy to do anything. Remember, specifically for your neck OSCE, if you are in a station where the presenting symptom is fatigue or low energy or memory issues or concentration issues, make sure you're ruling out depression as a cause for those symptoms. Uh, Patients who are elderly, they do not present with depression or fatigue. They usually come and say, I'm having trouble remembering things. Remember, for dementia and depression, this is a very important clinical clue. If patient comes himself or herself and says, I'm having issues with remembering things, think of depression as a differential diagnosis. If patient is brought in by family members and family member says that they're concerned about the patient's memory, it is likely to be dementia. Once again, dementia can be caused by the depression that is hiding in their presentation of memory issues. Adolescents or teenagers, they usually don't come to clinic with depression. They come with irritability, or their parents bring them in saying he gets angry very quick. He's not talking to anyone. He's staying in room all day, or she's staying in room all day. These are some presentations that you may have for depressive disorder or patients with depression. Remember, the criteria is again, MyPass ECG, MI, mood, interest, psychomotor agitation or retardation, appetite changes, sleep, sexual and suicidality, and energy concentration, guilt or worthlessness. If you come across any scenario or any situation where any of these symptoms is the presentation, make sure you follow up with the questioning for how long it's been going on and how you can ask all these questions of depression without making it obvious to the patient. Since if you directly ask someone, are you depressed? They may feel offended or they may not like the question that way. One important thing is that if someone is presenting with symptoms of depression, make sure you ask them about suicide. You can phrase it directly, say, do you feel like you would be better off dead? Or you can say it indirectly, however you feel comfortable and you think the patient would be more comfortable answering, make sure you're assessing them for suicide. We will go over the criteria for suicide or the risk assessment for suicide. The mnemonic is said persons, and then we will discuss what each term means. If someone has active thoughts of killing themselves or suicide, they need involuntary admission to hospital. For example, if someone says, I think I am going to kill myself and I have a gun at home, you cannot let them go back to home. If someone says, sometimes I get this feeling that I would be better off if I'm dead, then these are passive thoughts. You can start them on medication with closer follow-up or more frequent follow-up. Now, how we classify depression. If someone has major depressive disorder, we can classify it as mild, moderate, severe, or severe with psychosis. Mild depression, once again, they meet the criteria, which is 5 symptoms present for 2 weeks of depressive episode, but their functioning is minimally impaired. Sometimes someone with mild depression would go to school, go to work, perform well at school or at work, but they would still be depressed. Moderate depression is when they or someone else can notice that their functioning is impaired. It's not to the level that they are at baseline. In severe depression, they will have marked impairment, sometimes even isolation or withdrawal. If it is severe with psychosis, they will have depressive DSM-5 criteria for depression and delusion or hallucination or both. In someone who has depression with psychosis, they qualify for involuntary admissions if it is determined that they can harm themselves or someone else. Now, how we manage depression. First thing is we talk to the patient about their symptoms and we do our initial assessment based on their history, physical findings, etc. We diagnose depression and then we determine how severe the depression is. The severity is what determines how we are going to start with medications or we are going to consider therapy first. Step one of treatment algorithm is assessing their condition in details. Assess the patient for suicidal thoughts, active versus passive, for episodes of mania in the past. If they have episodes of mania, remember you cannot start them on antidepressant. They need mood regulators or medications to help with mood stabilizers, like lithium. If they do not have episodes of mania in the past and they're depressed, so we call it unipolar depression. If they have bipolar or mania or hypomania in the past, then that is bipolar. We cannot start those patients on SSRIs or any other antidepressants. Second step would be to screen patient for comorbidities. See if they have any issues with substance use, see if they have any medical conditions that could be causing their depression, like hypothyroidism or disability or anything that can make someone isolated or feel withdrawn or feel depressed. Screen the patient for anxiety. Sometimes depression and anxiety occur together. If it is initial visit, you don't need to plan document you don't need anything else. But if they're representing again for depressive episode, you have to document their duration of last episode, what they responded to, medication specifically, like SSRI, or was it just psychotherapy that helped them, and how long they took the medication, and how many episodes they have had. This will determine how you plan your treatment. If someone is presenting with the first episode, usually they start antidepressants, and once their symptoms resolve, after that, they continue for 6 more months. If it is a second or third episode, in those cases, we consider longer, sometimes lifelong treatment with an antidepressant. It is important to also obtain their family history, see if they have any medications that they're taking on a regular, which can either cause depression or interact with the medications we are starting. And remember to do lab work. TSH, thyroid stimulating hormone, CBC, liver renal function, this should be the minimum to do. ECG, if you are considering using medications like citalopram, which can cause QT prolongation, in those cases, you can consider doing an EKG or an ECG before starting the medication. Now, how we how we plan our treatment approach. Someone who has mild depression or mild to moderate, their functioning, their thought process is not very impacted. We can consider psychotherapy, either cognitive behavioral therapy or uh, intrapersonal therapy, etc. This would be our first line. We monitor them for 2 to 4 weeks for response. If they do not respond to CBT alone or IPT, we consider adding an antidepressant. Someone who has moderate to severe depression or severe depression, for them, the combination of psychotherapy plus antidepressant is preferred. And it has been shown with research that this has better response compared to monotherapy with either psychotherapy or with antidepressants. Someone who has severe depression and is currently presenting with suicidal thoughts or psychosis, they need urgent psychiatric review. Family medicine has to either get them hospitalized immediately or send them to urgent psychiatry centers. For example, there are some hospitals which are offering rapid access mental health support. We consider hospitalization for someone who is depressed and actively suicidal. For example, they have a plan or an intent to commit suicide. In that case, it is involuntary. They do not have a choice. If someone is depressed and they have passive suicidal thoughts or suicidal thoughts without a plan or intent, in those cases, we can consider either starting medications and monitoring closely, or we can consider elective hospitalization. Involuntary is not indicated in those cases. If someone has depression and is presenting with psychotic symptoms, they have to be started immediately on antipsychotics. There is a new treatment modality that we call electroconvulsive therapy. Basically, 2 or 1 electrodes are placed on the temporal area, and electricity or electric shock is given to cause a convulsion. This helps with controlling depression symptoms. Sometimes it can help with psychosis too. ECT is for few cases. If it is treatment resistant or refractory depression, we can consider it. In patients who are presenting with depression and psychosis, and there is contraindication to use antipsychotics, or there is another reason or indication for using electroconvulsive therapy, we can consider it. Sometimes we can consider this for pregnant patients who are not responding to SSRIs or safer medications that we have for depression. Now, medications that we use, we have first line medications and second line. First line, I think everyone knows SSRIs are almost always the first choice that we use in clinical practice. SSRIs work by blocking the reuptake of serotonin in the synapses and increasing the serotonin level by that mechanism. The most commonly used is sertraline and escitalopram. For adolescent or someone who is a teenager, we usually start with fluoxetine. Paroxetine is contraindicated during pregnancy, but is safe in breastfeeding. So sertraline, we start at 25 or 50 milligram, and we can go up to 200 milligrams. Escitalopram, we can start from 5 or 10 milligrams and take it all the way up to 20 milligrams. Citalopram, this can cause QT prolongation. Make sure you're not using it in someone who has congenital QT syndrome or someone with cardiac comorbidities. Fluoxetine is a safe choice for adolescents and teenagers. Paroxetine is safe during breastfeeding. Fluoxamine, it has a lot of interactions. It is not used in most cases. In some cases, it can be considered. That is beyond the level of this class. Now, how serotonin reuptake inhibitors work? They block or they inhibit the pump that reuptakes serotonin. And by this way, they increase the synaptic serotonin levels. The advantage of using a serotonin reuptake inhibitor is that they are first line. They have been shown to have good efficacy. They are very safe. They have minimal side effects, and most patients tolerate them well. And they have very few drug interactions, except fluoxetine or fluoxamine, etc. They have some interactions, but other than that, sertraline, citalopram, these have very few interactions. Side effects are mostly transient. When patient starts the medication, they may feel nausea, headache, sleep, insomnia. The weight gain is one issue with SSRIs. Patients can experience weight gain because it improves appetite too. Remember, serotonin we discussed improves appetite too, or works on appetite too. In very elderly patients, we should be wary of hyponatremia because SSRIs, sometimes they may cause something we call syndrome of inappropriate ADH, which causes uh, absorption of excess water from absorption of a lot of water from the kidneys, and then plasma volume dilutes, and this causes low sodium, even though the sodium was normal if they had normal volume of fluid in their intravascular compartment. One problem with SSRIs is that they take about 4 weeks, even 6 weeks to respond. And in some cases, particularly in younger patients, use of SSRI can cause them to actually act on their suicidal thoughts if they have any. Problem with SSRIs is that they improve the energy or the will or the willpower or energy quicker than they improve the mood and hopelessness. So if patient starts SSRI and they have those passive thoughts of hurting themselves, it is possible that they get the energy to actually commit on those thoughts. Depressed patients, like we already discussed, they have very low energy. They usually do not act on their thoughts of suicide. But if we give them SSRIs, sometimes it raises their energy fast, and their mood and other symptoms are still there. They can actually act on their suicidal thoughts. Second line of, not second line, but the second group of medications that are first line are SNRIs, or serotonin norepinephrine reuptake inhibitors. We have three medication in this: venlafaxine, duloxetine, desvenlafaxine. These medications, they work best for depression that also has anxiety with it. Remember, especially venlafaxine, or commonly found as Effexor is the brand name for it. If we start it on a higher dose, or if the dose is titrated up, sometimes it can cause BP or blood pressure to go up. That's why we have to monitor blood pressure for patients taking SNRIs. Duloxetine, it's interesting because sometimes it is used for chronic pain with depression. If someone has chronic pain, you can use duloxetine. If they're depressed plus have chronic pain, then duloxetine becomes drug of choice for them. One good thing about SNRIs is that their sexual side effects are not as common as SSRIs. But again, if someone gets sexual side effects from an SSRI, you cannot switch to SNRI. You have to either add bupropion or switch to bupropion altogether. Now, mechanism of SNRIs, they block reuptake of serotonin and norepinephrine. And this way they raise levels of both, and this can help in energy levels and dealing with patients who have depression plus anxiety. They may have fewer side effects than SSRIs, but they cannot replace SSRIs if sexual side effects do occur. Now, some issues with SNRIs is that they can cause jitteriness or feeling like the patient is very anxious in the initial phase of treatment. and they raise blood pressure depending on the dose, especially very pronounced with venlafaxine. And if you discontinue them suddenly, the discontinuation syndrome or the symptoms that you get from discontinuing SRIs or SNRIs, they are very pronounced. That's why it's recommended to, for all antidepressants, we recommend tapering then discontinuing, especially with these group of medication. Some atypical antidepressants that can be used as first line, they are norepinephrine dopamine release reuptake inhibitor like bupropion. Uh, Bupropion is good for people who experience sexual dysfunction with SSRIs. We can consider bupropion for them. It doesn't affect weight, but remember, you cannot give bupropion to someone who has seizure disorder or they have eating disorders. We have another atypical antidepressant, mirtazapine. Mirtazapine helps with sleep, weight gain, and insomnia. Uh, it's also its side effects. So patient who has depression and insomnia or depression and weight loss, and you want their weight to come up too, along with treating their depression, mirtazapine would be a drug of choice. There is a new medication class, vortioxetine. It comes in the brand name of Trintellix. Um, it is reuptake inhibitor and also modulates the receptor to make it more effective for the serotonin to act on the distal or the nerve that's receiving the signal. Vortioxetine, it doesn't have any sexual dysfunction issue, and it also improves cognition or memory. So you can consider it in elderly, but remember, again, it has side effects, and sometimes some patients have reported urine retention with it or um, prolonged duration between urination. So make sure you're not giving it to someone with BPH or other issues that can cause their urine symptoms to worsen. Uh, there is a medication that's used only in other countries. Canada hasn't approved it yet. It is melatonergics, works similar to melatonin. It is beneficial for patients who are depressed and have sleep or circadian rhythm issues, but Canada hasn't approved it. So it's here just because I want you to know that it is an option, but it's not going to be tested on exam. Now, we have second line antidepressants, tricyclic antidepressants like amitriptyline, nortriptyline, imipenem, things like that. These were first line previously, and they're used if the first line agents fail or they are contraindicated. Some indications are still there for these medications. For example, amitriptyline is used as an hypnotic or to help with sleep. Imipramine is used in some countries for children who have nocturnal enuresis or children who cannot control their bladder at night, but it's not used in Canada. Canada has desmopressin as the drug of choice for children who cannot control their bladder at night. We have some atypical antipsychotics like quetiapine and aripiprazole. They are used in cases which are very severe or cases of depression that also have psychotic features like delusions or hallucinations. There are some other agents like trazodone. Trazodone, again, it's similar to, not similar, but it also helps with sleep. One very known side effect from trazodone is that it can cause priapism in men. We have moclobemide. We can use them as augmentation and in specific situations only. They are not for everyone. Okay, I think we should stop after this slide. So how do we choose what we are going to start our patient on? Drug of choice is almost always an SSRI unless there is an indication not to use it. Mainly escitalopram or sertraline. Any of these are started. Fluoxetine is for teenagers or adolescents. SSRIs are safe. They have been studied. They have very good evidence of efficacy. They are tolerated well, their side effects are few, their interactions are few. If there is no response from SSRIs, or there is another indication to use an alternate to SSRIs, we can consider SNRIs like venlafaxine. SNRIs, they help in improving energy. But remember, if we are improving energy quickly without improving the depression symptoms, we may end up harming patient instead of helping them. Remember one key point for exam: all the first line antidepressants that we discussed, they have almost similar efficacy. Choice of medicine depends on patient and how their comorbidities are. I think this should be enough for our first lecture.